Here is something that should make you really angry. The cardiovascular disease is the number one killer of women worldwide. It's not a breast cancer, it's not an ovarian cancer. It is the heart disease which kills more women worldwide than all cancers combined. And yet, the image we have of heart attack is the middle aged man who suddenly clutches his chest. The diagnostics criteria were built on male patients. The clinical trials that established protocols of heart disease management and treatment were involving mostly male subjects. And as a PhD in molecular biology, pharma scientist, I want to explain you in depth what are the molecular mechanisms of heart disease development in women, why they are so different, and what are the typical female risk factors. First of all, let's start with basic anatomy because many people don't know about it. So, first of all, women's heart is quite small compared to men, even adjusting the body size differences. Women have also smaller ventricular chambers, thinner ventricular walls, and narrower coronary arteries, which makes also the stent placement surgeries, for example, quite difficult. Another aspect I want to talk is the troponin molecule. The troponin molecule is this specific marker which shows the heart muscle damage, and these troponin molecule thresholds levels are established on male dominant data. And when there is a heart damage happening, the troponin is increasing significantly in women, but it still stays lower than men calibrated troponin threshold. Women have also longer QT intervals. This is the time that in our heart's electrical system needs to recharge after each beat. And there are some drugs which, as a side effect, also increase these QT intervals, like some antibodies, some antihistamine drugs. Imagine now that women is getting, again, men calibrated concentration, the dose of these drugs, how dangerously it can affect women's heart rate. Molecular mechanism of atherosclerosis development and heart attack onset are also very different in women. So the classical picture of heart attack that we have is this: plaque forms, it ruptures, and it blocks the artery. And plaques consist of cholesterol, inflammatory cells, calcium, and some fibrosis tissue. In men, this fibrosis cap suddenly ruptures, it releases its content, which blocks finally the artery. And then there is an obstruction which is quite visible on the angiography, and there is also sharp pain during a heart attack on the chest area. In women, on the other hand, this rupture is not happening. Rather, the erosion is starting to develop slowly from the inside of the plaque, which in the end forms smaller plaques, and then there are always a partial obstruction of the artery. This is frequently missed by a standard angiography. There is this condition called MINOCA, myocardial infarction with non-obstructive coronary arteries. Women has a heart attack, they develop higher levels of troponin molecule, but on the other hand, angiography doesn't show it. So for decades, this was dismissed as not a real heart attack. It's a real heart attack, just a different mechanism requiring a different treatment. So estrogen protects your cardiovascular system from multiple simultaneous molecular mechanisms, and after the arrival of menopause, suddenly these all are removed. So, estrogen promotes the production of nitric oxide, which helps your vessels to stay dilated, healthy, and flexible. It has also direct anti-inflammatory effect on your vascular inner lining, vascular endothelium. Estrogen increases also insulin sensitivity, and we know that insulin resistance can lead to atherosclerosis development much faster. Indeed, women's cardiovascular disease development risk rises sharply after menopause, not because of aging, it's just because estrogen's protective effect is suddenly gone. Women frequently experience atypical cardiac symptoms. Atypical because they don't match a textbook explanation and they are attributed to anxiety. So, this section could save your life or someone's you love. So, what is this classical textbook heart attack description? This is the crushing chest pain which is radiating to the left arm. Indeed, in women, it can have a different onset. So, there are standard risk factors of cardiovascular disease development, which is true both for men and women. Those are like family history, diabetes, high blood pressure, obesity, smoking. But there are also risk factors which is typical only for women, and usually they are dismissed and neglected. Additional female specific risk factors are the following: First, preeclampsia. Preeclampsia is a condition which women develop during their pregnancy. This affects vessels and endothelium. But after the pregnancy, it increases also significantly risk of cardiac disease development. Second is the gestational diabetes. Even fully resolved after the pregnancy, it still increases the risk of metabolic and cardiac disorders. Premature menopause is a significant independent risk factor of cardiac disease development. Autoimmune conditions like lupus, rheumatoid arthritis elevate cardiac risk significantly because of their chronic inflammatory effect on the entire body. Increase of androgen levels, insulin resistance during PCOS can also lead to the increased risk of cardiac events in women. Unfortunately, most of those risk factors will never be asked during your routine consultation unless you raise it yourself. As a molecular biologist and just a woman who cares, those are two practical actions that I want to give for this week. First, audit your female specific cardiac risk profile. Ask yourself honestly, have I had a preeclampsia or gestational diabetes? Do I have PCOS, autoimmune disease? Have I had a premature menopause? Is there a family history of heart disease in women, mothers and sisters, not just coming from fathers? And second, memorize atypical symptoms right now. Those are jaw pain, neck pain, upper back pain, nausea, extreme unusual fatigue, shortness of breath without chest pain, cold sweats. If you experience those symptoms, especially in combination, do not wait until it passes away. And if you feel dismissed in a medical setting, just say this: I'm aware of atypical symptoms of cardiovascular disease. Please do ECG and troponin level examination until the cardiac cause will be ruled out. Only this sentence shows already that you know the evidence. You name what you want, and it makes already the dismissal clinically harder. So please use it.